I'll be moderating along with my co-moderator here, Blair, wherever he is. No watching movies on your personal devices. The bandwidth is apparently limited, so streaming is discouraged. Try to restrict it to important stuff like email. Anyway, we'll get started here. The first talk is on personalized GERD management, building multidisciplinary consensus, and it will be presented by Rena Yadlapati. Rena? I know you're here, Rena. I was just talking to you. Oh, there she is.
All right. Good afternoon, everybody. It's really a privilege to be speaking today, and so impressive to see this turnaround and what AFS has become. So we're going to start off this session talking about personalized GERD management, and I'm specifically going to focus on multidisciplinary consensus. So where are we today in consensus amongst our disciplines? So these are my disclosures. So the story of multidisciplinary consensus for GERD starts off with the very simple truth that patients that we see with GERD are not one and the same, right? So this morning, we heard from Peter Kurylas and John Lipham about how the mechanisms for GERD vary tremendously. Could be a defect in the anti-reflux barrier, esophageal dysmotility, hypersensitivity. On top of that, where we are now in 2019, we have an expanded armamentarium of treatment options for GERD. So we have some old therapies, our surgeries. We're also going to be hearing from leaders in the field about newer emerging therapies, but they span from endoluminal interventions, pharmacologics, and behavioral interventions. So we're at a point now where in GERD, one size does not fit all. And there is a critical need to personalize treatment strategies to the mechanism of action. We've heard about different types of patient scenarios today. So for instance, we all had that patient that comes in with a large hiatal hernia. It's not reducible. The patient's continuing to have reflux of bolus. No matter how many medications you give that patient, you ask them to sleep upright in a hospital bed, that patient needs repair of their crural defect and an anti-reflux intervention. But then we've also had the patient at the other end of the spectrum, right? A new patient that comes into our clinic, they had surgery, but as you get to know the patient, they probably had functional heartburn to begin with, and now their quality of life is miserable. They're probably worse off than where they were before. And you think back and wish if only we had targeted their psychosocial aspects and neuromodulation. Now, what complicates this further is that multiple specialties manage GERD. And that's really the premise of American Foregut Society, right? We're here as gastroenterologists. Some of us that focus on esophageal motility, some of us that are advanced therapeutic GIs. Then there's surgeons, and some that focus on foregut disease. But then our colleagues in ENT, pulmonary, internal medicine, they all manage GERD. And we know that the recommendations from these different disciplines, sometimes they can vary, sometimes they're at odds with one another. So it's not surprising that our practice patterns across disciplines vary also. So this data comes from a poll that we conducted over the past couple years, where we just simply asked key opinion leaders in esophageal motility, therapeutic GI, and foregut surgery. In the past year, how many have you performed or referred? So what we see is when we ask for laparoscopic fundoplication, nearly everybody's referred or performed this procedure. But when we look at magnetic sphincter augmentation, we start to see a difference where the surgeons are performing or referring more. Similarly for TIF, the interventional GIs are performing or referring for more of these. And then for radiofrequency energy delivery, it's really a mixed bag. So where we are right now is that GERD is a chronic, complex, and prevalent health condition that's managed across disciplines. And there is a critical need to develop multidisciplinary, evidence-based, personalized care pathways for GERD. So I'm going to be focusing on the multidisciplinary component of this. So imagine that you're in your clinic now and you're seeing a new patient, okay? This is a 32-year-old man that's experienced heartburn in the past. He underwent an evaluation, he had no erosive reflux disease, no hiatal hernia, but did have wireless pH testing and GERD was confirmed. He's been on a PPI and he's had a fantastic response. So this is a complete PPI responder. The reason why he's coming into your clinic is because he wants your guidance. He's not opposed to staying on a PPI long-term if it's recommended, but he's also open to other management strategies. So I want you all to think to yourselves, when you see this patient in clinic, which I'm sure all of us have, what would you recommend? And also, what would you not recommend? Some things that may be crossing your mind are laparoscopic fundoplication, magnetic sphincter augmentation, TIF, radiofrequency energy delivery, or medical and lifestyle optimization. So over the past 2 years, we conducted a couple national initiatives to try to get at this question, where we worked with experts in the field across different disciplines to understand what is expert opinion, where is consensus, and where are we not seeing eye to eye. And we posed these exact patient scenarios. So when we asked the key opinion leaders in esophageal motility, which of these recommendations are appropriate for this patient, 80% agreed that it is appropriate to recommend medical optimization. But a minority felt that endoluminal or surgical interventions were appropriate. Now, what about when we asked the therapeutic GIs and foregut surgeons? So this is a different story. Now, first of all, what we're seeing between the therapeutic GI group and foregut surgery group is that their responses mirror each other. But they're different from the esophageal motility perspective, where they would recommend medical, surgical, and endoluminal interventions. So what this is starting to highlight is that this patient, depending on what clinic they went to, they may have received completely different recommendations. And this is a problem. You know, as a society, we need to send unified messages to our membership, but also our patients. So why are we not seeing eye to eye? Why is there a lack of consensus? Well, when we've been in these roundtable discussions with the KOL groups, started picking up on a few different things. It seems like there is a group of thinking that if the patient's doing well on a PPI, why rock the boat? Why put the patient through an intervention that has its own risk profile? But then there's also a different thinking that we know that PPI responders tend to have better outcomes to these interventions. So why not do a one-time intervention for this patient and avoid long-term PPI use, which may have some risks also? Okay, now let's go back to our clinic and think about a different patient. So this is a 54-year-old woman. She's also presenting with heartburn, has non-erosive reflux disease, but this time she has a 3-centimeter hiatal hernia and previously proven GERD. So when you see a patient like this in your clinic, think, what is usually your next step in evaluation or recommendation? Some of you here may recommend pH impedance testing on PPI. And this diagram here is borrowed from the Lyon consensus. So in the Lyon consensus, they recommended that if a patient has previously proven GERD and persistent symptoms despite PPI, they recommend pH impedance testing on PPI to try to understand why the patient has persistent symptoms. Maybe the patient has PPI refractory GERD. Perhaps the GERD is controlled, but there's a component of reflux hypersensitivity. Or perhaps the GERD is controlled and there's a completely different reason for the symptoms. So if you did perform pH impedance testing, you then may be able to guide your recommendations based on what the testing tells you. So again, if we go back to the national initiatives that we've been conducting, and we asked our 14 KOLs in esophageal motility which recommendations are appropriate for this patient based on the pH impedance findings. This is what we see. So we see a lot of red here, which means that a recommendation is inappropriate. We see 1 as green. So if this patient exhibits breakthrough acid exposure, then a laparoscopic fundoplication would be appropriate. Now, what happens when we ask our proceduralists? So here we asked 15 KOLs. There were 8 surgeons and 7 interventional GIs. And I was really surprised by this. So the discussion started off with a big question mark from the group. Why are we even testing further with pH impedance on PPI? And this actually ended up being a very eye-opening discussion. So they brought up some really interesting points. 1, where is the data to guide the role of negative pH impedance testing to guide our anti-reflux management? Or if a patient already has proven GERD and a hiatal hernia, how does pH impedance add any value to your decision-making? So this was a lengthy discussion, but after we got past it, they did rank the scenarios, and this is what we found. So there's a lot more green, a little bit less red. But what's really interesting here is, if you look from row to row, the responses are identical. pH impedance did not guide the decisions for anti-reflux management for this patient and for the proceduralist group. For instance, if this patient underwent pH impedance testing and it showed a component of reflux hypersensitivity, if we ask the esophageal motility group, they may recommend neuromodulation, perhaps with a tricyclic antidepressant, perhaps with GI psychological interventions. When we ask the proceduralist group, the recommendations are anti-reflux surgery. So again, there's clearly a lack of consensus. And there's probably a good rationale for both of these sides. A lot of these points have come up today in prior discussions. So first of all, is there a role for pH impedance testing when we have a patient that presents with PPI non-response? And if there is, then we need to standardize this across our disciplines. And if there are questions that are unanswered, we need to make this a research focus. Also, if we have a patient with reflux hypersensitivity, should we be trying to target the brain-gut axis with neuromodulation, or should we be trying to target the anti-reflux barrier, or maybe a combination of both? So I think we all would agree that we need to move towards personalized management strategies for GERD, but multidisciplinary consensus is integral to this, and we still have a lot of work to do here. Just a week ago, when I was putting my slides together, I got this in my email. It was the most recent issue of the AGA Perspectives, and it's our very own Dr. John Lipham and David Watson, and they were debating the role of links for GERD surgery. And when I first saw this, I thought, wow, I should have just started my talk and ended my talk with this issue, because it really just nicely summed up the state of multidisciplinary consensus right now. But then it also reminded me of an AGA Perspectives from 2015. This was titled Finding the Sweet Spot. And it was a debate with John Hunter, Peter Curlis, and John Pandolfino, where they discussed the role of PPI and endoluminal therapies for GERD. That was 4 years ago. Clearly, there has been inertia in our field for years, if not decades. But I think the American Foregut Society is really a wonderful opportunity for us to tackle this. We can really make leaps in our field. We can leverage all of our interests and experiences to try to work towards consensus. So I'm going to end on an optimistic note, and bear with me, but I think it's really the time now for us to break down our boundaries between specialties and to understand each other's perspectives. I think the time now is for us to bridge our gaps so that we can align what are our goals for patient care, because that's the most important thing at the end of the day, and also what are our research priorities. And I think together we can really start moving the needle forward. At the end of all of this, I think it's like what my mentor has always told me. There are two sides to every story, and the truth usually lies somewhere in the middle. So thank you so much for your attention.